Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 343 of our pharmacotherapy series, entitled Care of the Critically Ill Adult. The next case reads, JKL is a 67-year-old male who presents to the intensive care unit with a 3-day history of cough and shortness of breath. JKL is diagnosed with severe sepsis due to pneumonia and is intubated on admission to the ICU. JKL is started on broad-spectrum IV antibiotics, including piperacillin, tazobactam and vancomycin. After receiving 6 liters of lactated ringers, JKL remains hypotensive, and a norepinephrine infusion is initiated to maintain his mean arterial pressure above 65 mm of mercury. JKL is placed on enoxaparin 40 mg subcutaneously daily and pantoprazole intravenously for deep vein thrombosis, abbreviated as DVT, prophylaxis, and stress ulcer, abbreviated as SUP, prophylaxis respectively. On day 3 of his ICU course, JKL develops acute kidney injury, abbreviated as AKI, secondary to sepsis or hypoperfusion, with his serum creatinine rising from a baseline of 1.1 to 3.4 mg per deciliter. JKL has a nasogastric (NG) tube placed for enteral nutrition. On day 6 of his ICU stay, JKL develops a severe Clostridioides difficile colitis for which oral vancomycin is initiated. So my question to you is, what are potential abnormalities of medication absorption in JKL? With the exception of intravenous administration, all medications must undergo absorption in order to reach the systemic circulation. Bioavailability, abbreviated as F, is defined as the percentage of the administered dose that reaches the systemic circulation. Gut function may be altered in JKL for a variety of reasons, including delayed gastric emptying, ischemic bowel, inflammation, and co-administration of interacting substances. Each of these issues may lead to significant delays and/or decreases in the amount of orally, enterally administered medication absorption. Delayed gastric emptying is a common occurrence in the ICU patient population, occurring in 40% to 60% of patients. It may be caused by many factors, including postoperative ileus, trauma, head injury, sepsis, burns, or opioid use. Delayed gastric emptying would be evident in JKL if he was manifesting high gastric residual volumes or enteral feeding intolerance. Because most medications are absorbed in the small intestine, delayed emptying would most likely affect the rate of absorption, slowing the onset of action of medications in JKL. Ischemic bowel may also cause JKL to have alterations in his ability to absorb oral or enteral medications depending on what portion and how much of the bowel is affected. In JKL, ischemic bowel may be caused by vasopressor use and/or the presence of a shock state. Because drug absorption occurs primarily in the small bowel, impaired blood flow to this area would be more likely to decrease the extent of absorption of medications. Acute gut inflammation may increase the absorption of certain medications in JKL. With the development of severe Clostridium colitis on day 6, JKL may experience increased oral absorption of oral vancomycin. Under normal patient conditions, oral vancomycin is not orally absorbed because of the ionization and large size of the molecule. There have been several reports of therapeutic plasma levels of vancomycin being achieved with oral treatment of severe Clostridioides difficile infections. The postulated mechanism is the severe inflammation in the colon, allowing for the passage of larger, charged molecules into the bloodstream. Oral medications are not the only route that may have altered absorption in the ICU. Subcutaneous absorption has also been shown to be remarkably altered in ICU patients, particularly those on vasoconstrictive, that is vasopressor, therapy. It is postulated that vasopressor treatment causes a decrease in subcutaneous tissue perfusion, resulting in impaired absorption of subcutaneously administered medications. Studies have shown that patients on low molecular weight heparin therapy also receiving vasoconstrictive agents have markedly reduced peak and total anti-tenor activity when compared to other hospitalized patients. My next question to you reads, how should absorption issues in JKL be managed? Generally speaking, when there is a question of gut function in the intensive care unit, intravenous formulations are preferred when available. In cases where a given medication would produce an objective response, e.g. antihypertensive or hypoglycemic agents, enteral therapy may be attempted to assess patients' response. As above, the pharmacist should be attuned to the specific pharmacodynamic response of a given medication to assess therapeutic response with oral or enteral dosing. In the case of JKL, consideration may be given to monitoring anti-factor tenor levels for enoxaparin, while he remains on vasopressor therapy. Trough levels of below 0.1 international units per milliliter have been associated with increased risk of the development of deep vein thrombosis. Additionally, if JKL is deemed suitable for enteral medication therapy, his proton pump inhibitor therapy could be changed to a dissolvable, i.e. Solu-Tab, formulation, which generally is preferred to crushing and dissolving oral tablets to prevent obstructing tubes and for ease of administration. Consideration could also be given to monitor serum vancomycin concentrations more aggressively, because JKL may be at risk for significant vancomycin absorption given his severe Clostridioides difficile infection, while also receiving systemic vancomycin therapy. My next question to you reads, what are the potential changes in the distribution of a medication in JKL? The distribution of a medication is defined briefly as where the drug goes once it is absorbed into the bloodstream. The extent of distribution of a medication is dependent on both physiochemical drug properties and patient-specific factors. The physiochemical properties of a drug that determine how extensively it distributes to tissues include lipophilicity and protein binding, with high lipophilicity leading to extensive tissue distribution, and lower protein binding contributing to more extensive distribution. Patient-specific factors that determine the distribution of a medication include weight, volume status, and vascular permeability. JKL has a multitude of factors that may affect the distribution of hydrophilic medications, i.e. medications with low volume of distribution. These include the presence of sepsis and large volume crystalloid, e.g. normal saline, administration. These conditions result in decreased plasma concentrations of hydrophilic medications, leading to potentially subtherapeutic concentrations. Patients who have sepsis may possess several factors that would lead to a decreased plasma concentration of hydrophilic medications. These include the presence of capillary leak, i.e. third spacing, causing intravascular fluid to distribute to tissues, the administration of large volumes of intravenous crystalloid medications, and reduced tissue perfusion. This is particularly well documented with antibiotic therapy in this patient population. Most infections occur in the interstitial fluid of tissues, thus interstitial antibiotic concentrations would be most relevant to determine efficacy. Studies have shown that the interstitial fluid concentration and subcutaneous concentration of antibiotics is 5 to 10 times lower and 1 to 5 times lower respectively in septic patients as compared to normal controls. Septic ICU patients may also have drastic changes in plasma protein, e.g. albumin, concentration because of reduced liver production and third spacing of albumin into tissue sites. Low plasma protein will cause an increase in the unbound fraction of drug, increasing distribution to tissues. Unfortunately, this increased distribution is more than offset by the increase in fluid concentration, secondary to capillary leak and volume administration, of the interstitial tissues, causing low concentrations of antibiotics in interstitial fluid. Understanding that the distribution of hydrophilic antibiotics in JKL, piperacillin, tazobactam, vancomycin, is likely increased in JKL, several strategies can be employed to offset these changes. Interventions include giving more frequent doses or continuous infusions with beta-lactam therapy, and using large initial doses, that is 30 to 40 mg per kilogram per day, of vancomycin in conjunction with targeting trough levels of 15 to 20 mg per liter. My next question to you reads, what are the potential alterations in metabolism in JKL? Drug metabolism can occur in a variety of body tissues, including the kidneys, GI tract, lung, and liver. The liver is by far and away the predominant metabolizing organ and is the focus of this section. ICU patients may have alterations in hepatic enzyme activity, liver blood flow, and protein binding, all of which may influence the rate at which hepatically metabolized medications are biotransformed. Liver metabolism is broken into two major categories: Phase 1 and Phase 2 metabolism, both of which transform drugs into more polar substances that are more readily excreted. Phase 1 metabolism refers to the cytochrome P450 enzyme system that works through oxidation, reduction, and hydrolysis. Phase 2 metabolism, in contrast, adds large polar molecules to the parent compound, including glucuronidation, sulfation, and acetylation. There may be significant factors that alter Phase 1 metabolism in JKL. These include kidney injury, inflammation, and hypothermia. Renal dysfunction can reduce Phase 1 metabolism through reduced hepatic cell uptake of medications and reduced biliary excretion. The inflammatory response secondary to trauma has shown variable effects on enzymatic activity, with reduction in CYP453A4, 2C19, and 2E1, with increased 2C9 activity. Therapeutic hypothermia has been well documented to reduce cytochrome activity across all isoenzyme families. This is especially well documented with medications commonly given to these patients, including neuromuscular blockers, fentanyl, phenytoin, and midazolam. It is important to consider that enzyme activity recovers during the rewarming process, necessitating close monitoring and potential dose adjustment. Hepatic blood flow, that is perfusion, may also be altered in JKL. Reductions in hepatic blood flow because of hypotension, that is shock, or shunting, as a result of cirrhosis, may have significant effects on prolonging the half-life of medications that are dependent on liver blood flow for metabolism. These medications are defined as having a high hepatic extraction ratio, E is greater than 0.7, and would include medications such as midazolam and fentanyl. Protein-binding alterations may also occur in the critically ill and may subsequently affect the metabolism of select medications. Specifically, albumin concentrations may acutely decrease, thus increasing the free fraction of medications that are normally bound. This is especially relevant for medications that have high extraction ratios, as more medication would be available for removal, causing a net reduction in drug half-life. The next question reads, how should metabolism issues be managed in JKL? To properly manage metabolism alterations in the ICU, the pharmacist should first be aware of the patient populations who are most likely to have altered metabolic rates or pathways. These include renal dysfunction, burns, therapeutic hypothermia, and decreased hepatic perfusion. In addition to identifying at-risk patients, the pharmacist should be aware of those medications that are most likely to have altered metabolism. These would include medications metabolized through the CYP450 system as well as those with high extraction ratios abbreviated as E is greater than 0.7. Increased vigilance in monitoring for therapeutic effect, toxicity with these medications in at-risk patients is warranted. The next question reads, how is elimination altered in JKL? Elimination is the process by which a drug or its metabolites are removed from the body. While the kidney is the main organ that eliminates medications, it is important to remember that there are other organs, e.g. the liver or lungs, that also may contribute to elimination. In addition, there exist several therapeutic interventions that occur in the ICU that also contribute to medication elimination, including continuous renal replacement therapy, abbreviated as CRRT, and extracorporeal membrane oxygenation, abbreviated as ECMO. Glomerular filtration is the primary method of renal clearance of medications, and renal drug removal is usually directly proportional to glomerular filtration rate, abbreviated as GFR. Acute kidney injury is a common comorbidity in the ICU population, occurring in 1% to 25% of patients, leading directly to reduced medication elimination. Other factors may increase the glomerular filtration rate in ICU patients, including trauma, burns, and use of vasopressors. Renal function assessment is critical to appropriately dose adjusting renally eliminated medications and proves to be especially difficult in the ICU population. The serum creatinine measurement often lags behind actual glomerular filtration rate, because there exist changes in creatinine production and altered tubular secretion. In addition, most estimates of renal function, including the Cockcroft-Gault C.G. equation and the modified diet in renal disease, abbreviated as MDRD, equation, were validated only in patients with stable renal function. Attempting to apply these equations to a patient with fluctuating serum creatinine measurements will result in inaccurate estimations of renal clearance. In addition to renal function, there exist other modalities that contribute to drug elimination in specific ICU populations. These include continuous renal replacement therapy and extracorporeal membrane oxygenation. While a detailed description of these processes is beyond the scope of this chapter, the clinician should remember that both may remove medications in clinically relevant quantities. It is also important that the pharmacist consider not only the elimination of the parent compound but the presence of active or toxic metabolites that require renal elimination. Examples of medications with clinically significant toxic metabolites are nitroprusside and meperidine. Renal dysfunction may lead to accumulation of toxic metabolites, causing patient harm. Common medications given in the ICU with active metabolites are midazolam and diazepam. These active metabolites may accumulate in renal insufficiency and cause exaggerated or prolonged sedation or delirium. The next question reads, how should elimination alterations be managed in JKL? Estimation of renal function is critical to appropriately dosing many medications in the ICU. As above, using the usual process of calculating renal function is often inaccurate, and typical equations, e.g. Cockcroft-Gault or MDRD, should only be used in patients with stable creatinine values. In patients with unstable creatinine values, consideration should be given to calculating creatinine clearance using a 24-hour urine collection. Other data points should also be considered when determining an appropriate dose in critical illness and include urine output, trends in serum creatinine, and the specific medication to be dosed. For JKL, this would mean frequent monitoring of vancomycin serum concentrations, anti-tenor monitoring for enoxaparin, and daily assessment of creatinine and urine output trends. Additionally, medications with active metabolites requiring renal elimination, e.g. midazolam, should be avoided if possible. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 344.